All right, this is a high-density briefing on the 2026 CVIT Expert Consensus for Rotational Atherectomy. There's been a significant update to the evidence base, so our goal here is a rapid distillation of the most critical changes for immediate clinical application.
We'll structure this to follow the procedural workflow. We're starting with the foundational evidence, then moving to pre-procedural planning, hardware, and core technique. After that, we'll cover the crucial topics of complication management and finally strategies for advanced lesions.
So let's start with Section 1, the key updates and the pivotal evidence. This is really the why behind the new consensus.
Okay, the evidence base has really expanded. 5 key trials are shaping our practice now. First up, the 5-year data from PrepareCalc. It confirms a significant long-term win for rotational atherectomy, or RA, over modified balloons in reducing target lesion revascularization. Second, DRO shows us that RA gets you larger stent expansion compared to orbital atherectomy in those really heavily calcified lesions. Third, RotaShock points to greater acute lumen gain with RA versus intravascular lithotripsy, or IVL. Now, on the other hand, Rollercoaster Eptic 22 establishes that IVL is actually non-inferior to RA for stent expansion. And finally, the dual prep registry gives a big thumbs up to a sequential strategy, image-guided RA followed by IVL, showing really high procedural success.
Moving on to Section 2, let's talk about pre-procedural planning and support. This is all about mitigating risk before you even start the ablation.
Here's a key recommendation. Maintain hemodynamic stability. Your target systolic blood pressure should be at or above 120 millimeters of mercury, and you absolutely do not want it dropping below 100. This is all about preventing complications, especially slow flow.
For managing hemodynamics and arrhythmias, a few points are absolutely critical. In patients with LV dysfunction and low systolic pressure, you need to consider putting in a prophylactic intra-aortic balloon pump. Why? Because waiting for a bailout IABP is associated with a much higher rate of MACE. For junior operators, temporary pacing is recommended for any RA in the RCA, a dominant circumflex, or the left main. And pharmacologically, it's fine to continue beta blockers, but the routine use of aminophylline just isn't there yet. The data is too limited.
Section 3. Let's get into the evidence-based toolkit, hardware selection and sizing.
Rotowire selection really depends on the situation. Now, the extra support wire gives you better ablation efficiency and helps straighten the artery. However, if you're not sure about guide wire bias, or for junior operators who are facing some uncertainty, the consensus is clear. Use a floppy-first strategy. And remember, if the burr just won't cross, exchanging the wire can sometimes alter that contact point just enough to let it pass.
The recommended burr-to-artery ratio is between 0.4 and 0.6, and this is critical. A ratio over 0.61 is tied to worse clinical outcomes. If you're going that high, you absolutely must use intravascular imaging to guide the procedure.
So, when do you use a second burr? Well, it's governed by these specific scenarios. If your first burr can't cross, you size down. That's a critical safety move. You size up when you're aiming for a large final burr, when imaging shows you haven't ablated enough, or when you see that classic dog bone phenomenon where a post-RA balloon just won't expand. That's a clear sign you need more ablation.
All right, Section 4. Let's cover the core atherectomy technique and how to optimize the whole ablation process.
The standard technique uses a pecking motion with a rotational speed between 140 and 190,000 RPM. And just a note here, while lower speeds might give you a bit more lumen gain, they don't actually reduce the risk of slow flow. Your runs must be limited to 30 seconds or less, and for junior operators, the recommendation is even shorter, 15 to 20 seconds. And here is a critical safety rule. Never deactivate the system while the burr is in the stenosis. You have to pull back to the platform first, or you risk entrapment.
Anticoagulation needs to be managed diligently. Your target activated clotting time, or ACT, should be maintained above 300 seconds. The absolute minimum here is 250 seconds throughout the entire procedure.
Okay, Section 5. This is a big one, complication management. We're going to detail the consensus bailout algorithms for major adverse events.
Managing slow flow is really a 3-part strategy. First, prevent it by minimizing debris. Use the right burr size, keep ablation time short. Second, prevent it by maintaining perfusion pressure. Keep that systolic at 120 or higher. And third, if it happens, you go to immediate bailout. Stop the atherectomy, watch for ST changes, and give intracoronary vasodilators like nitroprusside.
For coronary perforation, prevention starts with good risk assessment, especially in those angulated or eccentric lesions. Use appropriately small burrs. But if it happens, the paramount #1 rule is this: maintain your wire position. Do not lose wire access. You have to remove the RA system over that indwelling rotowire. Then immediately get ready for a covered stent and pericardiocentesis, and get surgery on the phone right away.
Now, let's walk through this algorithm for burr entrapment. Step 1 is a gentle pull, no activation. If that doesn't work, your next call is to surgery. Get them on standby. Now you hit a decision point based on your guide catheter. If you're in a single guide system, 7 French or smaller, you have to cut and retrieve the drive shaft sheath. This is to make room for a second wire and a bailout balloon. If you're in a larger guide or a double guide system, you can just advance a second wire directly. Either way, the goal is the same: inflate a balloon just proximal to the burr to create some space for retrieval. If you get it out, you then assess for injury. If you can't, at any stage, the patient goes to surgical bailout.
On the left here, you can see that technique for cutting and retrieving the drive shaft sheath, which, as we just discussed, is essential for bailout in smaller guide systems. On the right, we have the algorithm for a drive shaft fracture, less common, but absolutely critical to know. The key decision point is whether there's coronary rupture. If there is, hemostasis with covered stents is your immediate priority. If there's no rupture, you try to remove the system as one unit. If that's not possible, you move to retrieval with balloon trapping or snares, with surgery always as the final option.
All right, our final section, number 6, advanced lesion strategies. This is expert-level guidance for some of the highest risk scenarios.
Certain osteal lesions present unique challenges. For the osteal RCA, the problem is you can't get true coaxial guide support, which means you're at high risk for non-uniform ablation. In osteal LCX lesions, you've got this dual perforation risk. The burr can either jump across to the carina or it can cut way too deep into that lateral wall. Both are potentially catastrophic.
The halfway RA technique is an essential safety strategy for long angulated lesions. It's simple. You only perform atherectomy on the proximal segment, right up to the angulation. The distal part, after the bend, you treat with a balloon. This avoids trying to force that rigid burr through a sharp angle, which dramatically cuts down your risk of entrapment or perforation.
2 very high-stakes scenarios need special mention. Unprotected left main. It's feasible, but there are non-negotiables. You have to start with small burrs, 1.5 millimeters or less, to prevent catastrophic slow flow. And you must use intravascular imaging to guide your final burr sizing. Stent ablation is reserved only for underexpanded stents. It has a high risk of burr entrapment and is absolutely not a procedure for junior operators.
So, what's the core philosophy driving this whole consensus? The authors put it perfectly, stating, "We provided the Japanese-style RA, which uses intravascular imaging devices to achieve the maximum efficacy without sacrificing the safety. That really underscores the central role imaging now plays in modern rotational atherectomy." This consensus really solidifies the role of intravascular imaging in maximizing both the efficacy and safety of RA. The biggest takeaway is a clear shift toward more proactive, image-guided strategies. And this leads us to the final, forward-looking question. As atherectomy and lithotripsy techniques keep evolving, how will integrated, image-guided algorithms completely redefine our approach to complex calcified disease?